Okay, here's the second part of the heart. We're starting with an electrocardiogram. You're going to be doing this in lab. The machine is called an electrocardiograph. It makes a recording of electrical activity moving through the heart muscle, which is called an electrocardiogram, which is abbreviated ECG or EKG because of its derivation from German. All electrical activity, whether it starts in the brain or in the heart or in muscle, eventually gets to the skin, and you can put electrodes on it and pick that activity up. Now, we're only going to go through the basics of this EKG. In an ECG class, if you were going to be an ECG technician, you'd go into this in way more detail than we are going to. All right, so you see a wave, actually three waves that make up a typical part of the ECG up at the top right. All right, this is electrical activity. So remember the SA node. Wait a minute, let me pull that down. All right, and then get rid of it. Okay, so the SA node releases an impulse over here. And remember that it's going to move through the atrial muscle, the myocardium, and that is seen as a depolarization wave right there. Now, the atria are not contracting yet. They don't start to contract until about right there. So you're looking at the electrical activity before the action as a result of it ever occurs. Okay, so remember it's then going to go to the AV node, which generates one in response, and it goes down the bundle, and it goes down eventually to the Purkinje fibers, all that jazz. Okay, so now we are going to move this depolarization wave through the ventricles, and there is the QRS. So there's the depolarization wave going through the ventricles, and they then will contract right there. Then after the contraction, the muscle is going to repolarize. You know what that means. And when it repolarizes and it goes back to its original charge, you get a T wave. And that's the wave going through the ventricles. And this, of course, precedes relaxation or diastole of the heart. So here is the relaxation right there. So again, this is contraction or systole of the atria. Here is contraction or systole of the ventricles. And here is relaxation of the ventricles. Now what you don't see is relaxation of the atria, or the repolarization wave, comparable to the T wave, of the ventricles. And it actually is occurring, but you don't see it on the wave because that repolarization wave occurs right here at the same time as the QRS. So if we could take the QRS away, you would see that repolarization wave of the atria. Okay, so let me get rid of all that stuff. All right, so what does this tell you? It tells you lots of things. For example, you've got a picture right here, which is mostly normal, but there's a few little things here. It's very fast. So it is tachycardia. If you look over here, you'll see the P wave is not there, and so there may be a heart block, or the atria are very weak. In this picture, you'll notice a very long time period right over there. That's a block. And right over here you see an extra beat where there shouldn't be one. And of course there's nothing after it. Here's the next cycle right there. By the way, each one of these represents a cardiac cycle, which we're going to talk about in a minute. Cardiac cycle, cardiac cycle, cardiac cycle. Each one of these is approximately 0.8 seconds. Okay, so if your heart rate is around 72 beats per second, action potentials not per second, per minute. If you multiply 72 times 0.8, you get 60 seconds. So if you divide 60 by 0.8, you get approximately 72 beats. Just to point out, it's going to be kind of hard to do it with the small pictures here, but there's a long time of relaxation. Remember, this is relaxation starting here, and it goes on until the next SA node activity releases its impulse. So this area right in here is relaxation. So one cardiac cycle goes from here to the beginning of the next cardiac cycle, the next release of the SA node impulse. So this tells you all sorts of things about the heart. By the way, you've got time on this axis, you've got intensity of the impulse going this way. You should be able to figure out why the QRS wave is so intense. I'm not going to give you the answer. Okay, so this leads us into the cardiac cycle about. All right, so remind yourself about all that stuff from chapter, trying to think what it was, 8, muscle. All right, so we're not going to go back over, resting potential and all that. Oops, I'm going the wrong way. Nope, let me go back this way. Nope, that doesn't seem to do it either. I'll just use an arrow. Well, somehow I jumped. Okay, so remember all this stuff about general muscle contraction in chapter 8. You've got to start out with resting potential. Remember, here's a muscle cell right there. There it is. You're going to have high sodium out here all around it. You're going to have high potassium inside. What maintains these two ion gradients is your ion pumps. They're embedded in the membrane. They help to pump the sodium out. They pump potassium in. Blah, blah, blah. Okay, so you got to start there before you can go to depolarization. Depolarization is the action potential. It moves along the membrane as a wave. This is actually going to be what causes the contraction, and then once that contraction is done, we get back to repolarization. In that process, remember, during the depolarization, the sodium and the potassium is everywhere because it's diffused so that it's equal across the membrane. So you've got both of them everywhere. In order to get back to repolarization, all the sodium has got to get kicked out. The potassium has got to get concentrated in, and we're back to resting potential. All right. Another important thing about cardiac muscle is rhythmicity, much more than any other muscle. Another important thing, leaky sodium channels. They tend to open up easier than in other kinds of muscle. Look how precipitous this upswing is here on the graph. That's telling you that the sodium channels very easily allow sodium through. You get a plateau here, right there, which you do not get in skeletal muscle, or smooth muscle for that matter. And again, you can also see that calcium is really, really important here for cardiac muscle, more than any other muscle. And you can also see that this is a longer lasting contraction. One more thing I should point out, I'm going the wrong way again. Yep, just jumps. Is think back to tetany that you studied in skeletal muscle. This refractory period, you see it at the bottom. That's the time period that during which if you try to re-stimulate the muscle, it won't contract because it's in this refractory period, which is the time when it cannot be re-stimulated. It's very long for cardiac muscle. That means that cardiac muscle cannot go into tetany like skeletal muscle can. You don't want cardiac muscle to go into tetany. Okay, so let's go through a cardiac cycle. There is an excellent, really excellent animation. You can see the website right there. I'm not going to go there. And you can look at that animation. Okay, so I've got 2 pages showing you a step-by-step of what's going on in a cardiac cycle. Cardiac cycle is the complete contraction and relaxation of all 4 chambers until the next SA node release of an action potential. 1 full cycle. 1 EKG if you like. Okay, so we start out over here. Let me get back to marker. Okay, here's your SA node. It generates an impulse. And that impulse now is going to spread into the atria. And the atria now are going to contract. Remember, that's the P wave of an EKG. Atria contract, that's called systole or systole. Now, at the same time that's going on, this action potential is going down to the AV node. There's the AV node somewhere right in there. And the impulse now travels down the bundle and down the 2 bundle branches and goes this way and gets to the Purkinje fibers. You see that right here. And as it moves up the Purkinje fibers, the action potential now is going to precipitate the contraction of the ventricles. Okay, so let's go to the next. And by the way, before we leave here, look at the EKG down at the bottom. So you can see the area of the EKG superimposed. So at the very last right EKG, you see that impulse going through the ventricles. We're right about at the point we're going to get them contracted now. Okay, so now, remember, blood has been pouring down into the ventricles. Now remember, blood's coming in this way, and blood's coming up this way into the atria, and it's coming in this way from the lungs. And the valves, remember, don't stop the blood from going down the ventricles. They just want, the blood just goes right down into the ventricles. The ventricles start filling up, right? Yeah? Pressure's going to start to increase. And at the point when the action potential goes through, the ventricle walls are going to press inward. Okay, remember the Purkinje fibers, so ventricle walls press inward in all directions. That really causes the pressure to skyrocket. Now, think about what's going to happen. The pressure increases. The AV valves are going to close because the ventricles are going to contract, and you don't want the blood going back up. You only want the blood going that way through the pulmonary and that way into the aorta. If those AV valves were open, the blood would regurgitate up. Okay, so when those valves close, they make the first heart sound. It's not from they don't close like a door. It's the pressure of the blood pushing the flaps closed. Okay, now at the same time, as the blood flows through the 2 major arteries, the semilunar valves open and the blood is ejected. That's called stroke volume. All right, now what's going to happen to the pressure? Pressure is going to fall in the ventricles. So now, once the pressure has fallen in the ventricles, the semilunar valves are now going to close. So remember, the blood went out this way and the blood went out that way. And now when the ventricles go into relaxation and there's no pressure push, the blood is going to want to drop back down, right? And remember, the blood catches on those little valve flaps right there, okay? That closes those valves. It makes the second heart sound. That's the dub. So first heart sound, lub, or lub, and second is dub. Okay, and when those close, you've now got blood coming through again, opening the valves up. And now for a brief period of time, all 4 chambers are relaxed. By the way, great website to see all this happening. It's called blaufuss.org. I believe they make some sort of mechanical stuff for the heart, but they've got some great tutorials, heart sounds, and showing blood flow, and blah, blah, blah. Okay, so that's one full cycle. All right, so I know this is busy, but you're going to have to kind of think about this. All right, so I wanted to show you some things. Look at atrial pressure. No, look at ventricular pressure here. It's the white line, and I've got ventricular pressure circled with a red right there. Okay, so I'm going to kind of draw on this. All right, so we're in, and D stands for diastole, relaxation, and S for systole. So blood, remember the ventricles are in diastole. Blood is coming in. The pressure starts to increase. The valves are going to close. There's your first heart sound right there. The ventricles are contracting. Look at the QRS right here. Here's your QRS. There's your impulse. There's the start of contraction. The pressure skyrockets and it pushes that blood out. And as the blood goes out, then the pressure in the ventricle is going to drop. And at this point, here's that T wave right there. We're now going to go into relaxation, and the muscle repolarizes. And now the AV valves open as blood pours through again. And again, look right there. The two valves, the two semilunar valves, now close. So remember, as the blood goes out into the aorta, that's aortic pressure you're looking at in blue. When that pressure goes up, that's going to close the valve. Same thing in the pulmonary. Other things to look at on this, look at your heart sounds down here. So here's the closure of AV valves. There's your lub for sound. Here's the aortic valve and the pulmonary valve closing right there. And there's your second heart sound. Okay, valve problems. You can very often hear it. It's called a murmur. And again, if you go to the Blaufuss, there's all sorts of sounds of murmurs. Look at these pictures of valve problems. By the way, it's estimated that something like 15 plus or minus a few percentage points of the population has a mitral valve prolapse. Prolapse meaning it goes backwards. So the flap kind of flips up into the atria, and that allows blood to regurgitate. So look at these valves right here, eaten away. That's a bacterial infection, endocarditis. Here, look at the valve flaps right here. They're hardened, and they don't flip open and close. They just stay the same orientation all the time. It's called a stenosis. And then over here, you've got damaged valves from rheumatic heart fever, which is what that is. Okay, so let's go through control of cardiac output. Okay, this is called cardiodynamics, and let me make a couple of definitions here first. Heart rate, you know what it is, number of action potentials per minute, the number of beats per minute, number of impulses released by the SA node. It's around 70, let's say. Heart rate. Okay, second, the amount of blood that gets pushed out during contraction of the ventricles, during systole. It's called stroke volume. Remember, it's the same amount, left side ventricle, right side ventricle. It's the amount that's ejected with every contraction. If you multiply those two things together, beats per minute, the volume ejected per contraction per beat, you get cardiac output. It's heart rate times stroke volume. This is important to know. If you're sitting there listening to this, you're probably pumping around 5 liters per minute. Heart rate 70. Your ejection volume is around 70. You multiply 70 by 70, you get 4,900 milliliters per minute. Let's round it up to 5 liters. Okay? Now, if I have you get up and do jumping jacks for 2 minutes, what's going to happen to your cardiac output? it's going to go up. It could even go up to 15, 20 if you're in good shape, but before you have to fall on the couch. That's called cardiac reserve. The amount of increase in heart function and cardiac output that you can have, that you can produce over your resting cardiac output. Obviously, athletes have got a big cardiac reserve. Okay, when cardiac output goes up, arterial blood pressure goes up. We're going to cover that in the next chapter. All right, so we're going to look at two things that affect cardiac output: heart rate, stroke volume. The things that affect heart rate, those things that increase heart rate, increase cardiac output. Those things that increase stroke volume, increase cardiac output. All right, stroke volume first. All right, where to start? All right, so during relaxation of the ventricles, all right, blood is coming into the ventricles right there. And now the ventricles are at their biggest. They're holding the most amount of blood. Right before contraction, you can see contraction happening there. All right, so the amount of blood in the two ventricles at the max volume during diastole, relaxation is called end diastolic volume. It's something like about 120 or so. Now, the ventricles are going to contract. They're going to go into systole. You see it happening right there. And blood is going to go out, obviously. And that's called stroke volume. And stroke volume is around 70. Now, again, 70 goes out the right side and 70 goes out the left side. It's the same amount on both sides. That's stroke volume. Now, at the end right here, after the blood has gone out during that contraction, there's still blood sitting in the ventricles. There's still blood here. Not all the blood goes out. All right? If you measure it, that volume is called end systolic volume. It's the amount of blood sitting in the ventricles at the end of systole. Don't make this harder than it is. And that is about 50 mils. So remember, end diastolic volume around 120. I'm averaging here. End systolic volume about 50. If you subtract 50 from 120, you got 70, right? And that's that stroke volume right there. Now, this other value right here, ejection fraction, end diastolic volume divided into stroke volume. So if you take 70 and you divide by 120, all right, and you multiply by 100 for a percentage, all right, because ejection fraction is always given in percent, you get this value, which is somewhere, for most people that are normal, between 55 and 75%. So if you're in good condition, maybe 75% of all the blood in your heart, as it fills up with during diastole, when it's relaxing to the max, will get pumped out. That's a very efficient heart. If you've had a heart attack and you've had a lot of damaged heart muscle and it just isn't strong enough to push a lot of stroke volume out, you're going to have a lot of blood remaining in the heart at the end of your systole, and your end systolic volume is going to be high, and that makes for an inefficient heart. Okay. All right, control of heart rate. We're looking at heart rate first. The number one thing that has an effect on heart rate, speed up, slow down, is the autonomic nervous system. So remember, hypothalamus and medulla are the major controllers here. The medulla is the most important here. Cardiac center, vasomotor center, we'll talk about the next chapter. Respiratory center, we'll talk about respiration. Two parts: cardioacceleratory center, that's easy to understand, cardioinhibitory center, cardioacceleratory, sympathetic, inhibitory, parasympathetic, neurotransmitters, you know all this, fight or flight, blah, blah, blah. Okay, so acceleratory center, fight or flight response. Inhibitory center, go back, restore to normal. Here's a look at the nerves coming down. Again, let's go parasympathetic over here. Remember your vagus nerve, nerve number 10, comes down from the brain, comes down the spinal cord, comes out here, goes down over here. For the sympathetic control, it's a spinal nerve. There's no cranial nerve that carries out those impulses going to the heart. Other thing that plays a part is the atrial reflex. It's called the right atrial reflex or atrial reflex. It resides right over here. And it's monitoring, it responds to, let me rephrase that, how much blood is coming in the vena cava. Okay, there are other things that can affect heart rate. Not as important as autonomic nervous system and the medulla. Hormones like T3 and T4 hormone increase metabolic rate of all organs, including the heart. And that's why people with hyperthyroidism very often go into have heart attacks and heart problems. Ion levels, we're going to cover that in another chapter. Potassium, sodium, calcium, high and low levels. Miscellaneous odd and end things like high temperature, you got a fever, your heart rate goes up. Physical activity increases it. And chemicals, caffeine, nicotine, all that. All right, stroke volume. Okay, the two main things are going to be, whoops, I didn't mean to do that. Oh, darn, I did it again. Wait a minute, get back. Okay. All right, so the two major things, preload and afterload. Let me start with those two. Okay, so notice it's in blue. Notice I put this in blue. There's the definition. It's called the Frank-Starling law, or Starling's law of the heart, also called preload. Ability of the heart to change its force of contraction and its stroke volume in response to changes in venous return, which means the more blood coming back to the heart via the vena cava, okay, venous return, and the more the ventricles fill with blood, the stronger the ventricles will then contract, and the greater your stroke volume will be. In other words, the more in, the more out. There you go. So if you're bleeding a lot, which means that you're in a car accident and you're bleeding out a whatever, femoral artery, and your venous return drops because the blood is going out on the ground instead of staying in your circulatory system, you're going to have less venous return, less blood coming into the heart, less stroke volume is going to go out as a result. All right, afterload. Now remember, you've got the heart pushing against the aorta. Let me pull a picture up here to remind you. Okay, so here's your view. All right, so remember that. The pressure, here's your aorta right there. Pressure is going to be really high here. The heart is pushing this way against the pressure that's high in the aorta. If you have really high pressure, hypertension, then the heart really has to more forcefully contract to push the blood towards higher pressure. And that's called afterload. In fact, you see a definition right there, resistance to blood flow. So obviously this is dangerous for the heart to push against this increased pressure. Okay. Contractility, strength of muscle. You've had prior heart attacks. The muscle's not as contractile. Obviously, your stroke volume is going to go down. Look at that in ESV, okay? So if stroke volume goes down, less blood going out, you're going to have more sitting in the heart, more ESV. Other things that can affect, again, autonomic nervous system, hormones, ions, blah, blah, blah. Okay, EDV. In diastolic volume, you've got to have enough time for your ventricles to fill with blood. Filling time. That means more venous return. If your heart is going a mile a minute, 320 beats per minute, which is fibrillation, there's not enough filling time for enough blood to get into the heart. So venous return drops, and the amount of stroke volume goes down, and it becomes a vicious cycle. Okay. So, to sum up all this stuff, here are major things that affect cardiac output. Heart rate and stroke volume, you see. Then for heart rate, autonomic nervous system is the #1 controller. For stroke volume, also sympathetic stimulation can have an effect, as well as the amount of fill and venous return coming into the ventricles. And then there are other things that can play a factor: hormones, blood gases, all that. Okay, so about done. Problems. Congestive heart failure. If the heart is weak due to myocardial infarctions, and the heart, let me change that. Let's do this in another color because it's red. Okay, so let's say that there has been some previous damage right in here. And because of the damage in here, this entire left ventricle cannot contract very forcefully. And what that means then is there's just not going to be enough cardiac output going out to get to the body. That's congestive heart failure. You can have it on one side, you can have it on the other side, you can have it on both sides. So think about what's going to happen. If this is a weak heart, then there's going to be more blood coming in than the amount of blood getting pushed out because the heart muscle is so weak. So you have a backup of blood, right? Now where is that blood coming from that would be going into the heart to get pushed out? It's coming from the lungs, right? The lungs are over here. So the blood starts backing up because it can't get pushed out well enough. And now you have blood leakage and plasma leakage in the lungs. That's pulmonary edema. So the symptoms have to do with the backup of blood to the area where the blood is coming from going into the weak side of the heart. On the right side, remember that the blood is coming from the body, right? Vena cava. So if you've got a weak area here on the right side, then you're going to have a backup of blood that is just sitting there not really moving very well in the exterior portions of the body, particularly the legs, because gravity is pulling this blood down to begin with. And if you've got bad venous return, it makes it all the worse. Okay, so that's congestive heart failure. Do not confuse that with coronary artery disease. It's a totally different problem. Okay, let me get out of this. All right. The other thing is, let's see, drop in venous return. Unfortunately, this is, let me get rid of this picture and move it up there so you can see it. That's what shock is. So, again, if you're bleeding out, blood's going on the floor or wherever, you have a drop in venous return, means you're not going to have enough, again, think about the Starling law, not going to have enough blood getting pumped out. That means you don't get enough blood getting to the tissues, to the heart itself, to the brain, to the kidneys, blah, blah, blah. That's shock. There's a nice website. Actually, there's quite a few on congestive heart failure. All right. Other problems. We've talked about arrhythmias. We've talked about murmurs. We have talked about coronary artery disease, also called coronary heart disease. We've talked about congestive heart failure. This picture down at the bottom right is a colorized X-ray. The interesting thing is the heart. Look at the size of this. It is humongous. It's like twice as big as it should be. Now, you might think an athlete would have this. No, I mean, they can have enlarged hearts, but their hearts are really muscly and well-toned. This is somebody who's got cardiomyopathy. They've got a diseased myocardium. And because their myocardium is very weak, the heart, in order to compensate to get the end diastolic volume up enough to push stroke volume out sufficiently, it's enlarged, which is a problem. Then up at the top you see a stent that is put into a coronary artery. Remember, occlusion of the coronary artery, heart muscle dies, blah, 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 myocardial infarction. And some people have recurrent closing obstruction of the vessels. They put a stent in that kind of forms a wall that keeps it from occluding. By the way, there are a lot of little movies at some of those websites I showed you in the first cardiovascular video. So, some things we've talked about, some things we haven't. Haven't talked about heart valves. Here's an example of one. Whoops. Right there. That's a prosthetic valve, or sometimes they still use pig valves. Various chemicals. Let me point out nitroglycerin and digitalis. Nitroglycerin is given as either a pill, you pop it under your tongue, or some people wear patches over their chest. It's a vasodilator, so it makes the coronary arteries dilate. So if there's an obstruction, there's still a better opportunity for blood flow to the heart muscle. Digitalis, a lot of people are on. That's the generic name. It makes the heart muscle more contractile. I've shown you an example of a stent. Angioplasty is just a type of imaging technique where they inject you with a radiopaque dye to look at the dye going through the coronary arteries to look for obstruction. Talked about pacemakers. Not going to talk about, I did mention bypass surgery, like doing a graft. They take a vein very often from the leg and graft it. If you've got really occluded coronary arteries, they put a new vessel in. It happens to be a vein, but it becomes an artery. Anyway, heart transplants, not going to talk about. Of course, some people, they're playing with artificial hearts. You can also get something called an auto transplant, which is kind of interesting. They take part of your back muscle. I don't know if it's the trapezius or the latissimus dorsi, and they actually wrap it around the heart, and it forms kind of a muscle coat that helps with the contraction. Rather interesting idea. And that's it.